And I'm going to say the same thing that I said in Chelmsford. I think that you were there. And very well point say that we were three CCGs, and we have Dr. Sunil Gupta with us from Consultation and Rutherford. So two of the three we are here today. And just to re-emphasize that me personally, and representing the Southend CCG, we didn't oppose to the consultation. We didn't oppose to the changes proposed. What we wanted to highlight is the importance of the care of the hospital and primary care in the whole context of the changes proposed. And what we highlighted is that any change that you want to propose from the hospital, they have to also be supported with changes of the hospital primary care. So our extension was because in that document, even if it's very focused on the hospital, they have some elements in it that they're talking about care in the community, care in their own homes, and care in the primary care. So we wanted to highlight the importance of that. And from that, the SDP is working. We're working on supporting primary care, and we have a steering group on primary care strategy. And part of that, we are meeting every week, some weeks twice a week. Relevant people working on a strategy that we hopefully will be ready in the next few months.
But I would say the most important thing about this is that the most important thing about this is that this is for me, and I've read the 491-page document several times, and each time I read it, it becomes more and more blurred and confused. And what we're actually now having is that at the end of this consultation process, which has actually been extended by 2 weeks for no real purpose, because actually the purpose of this consultation is just to tick a box. Yeah. What they're now asking you to do, as heads of CCGs, is go and make their, let's be absolutely honest about this. Without the 140,000 staff that don't exist, they're asking you to make an unworkable plan work. And what they're going to do is exactly what I heard in Chelmsford, which is they are looking, at the end of the day, to once again scapegoat the CCGs, or to scapegoat general practice, which has been run down so badly in this area. So what you're being asked to do in 12 weeks is to make their unworkable plan work. And I don't really think that can happen. And I think what we need is not to be expecting this to start in September, but to be expected to go back to the drawing board, to actually talk to people like Safe Southend NHS, like some of the people that are involved in recruitment, like some of the people that can actually make this happen, instead of pretending there are so many staff out there that are going to all of a sudden materialise in the NHS to make this plan work, because it won't. And the whole point is that, in the light of the fact that the government intends to cut £22 billion from NHS spending by 2021, in actual fact, all this is about...
to make a speech?
No, I'm not. I'm just trying to make...
Really?
Well, okay. But if you don't believe that this is happening, then in actual fact, I'm sorry, but you're missing the whole point of this. And that is that this is not an issue of restructuring or reforming. It's an issue of the fact that for 20 years, the NHS has been run down staff-wise, and the biggest elephant in the room here that nobody's mentioning is that there are too few qualified staff working in the NHS, and that has got to change.
Thank you. Thank you. So we've got lots of questions to get through. The first one, we've tried to theme them across the range of themes that are emerging. The first one relates to transport, and it's Michelle William. Could you raise your hand, please?
Before we start the questions, could we be introduced to the panel?
Oh, sorry, I've been asked to do that as well. Yeah. I was slightly distracted. No, that's fine. We've all got microphones, so...
So you know me, I'm Senior Skinner, the Chief Medical Officer. My name's Emma Gray, and I'm a General Surgeon. Oh, at Southend. I'm Claire Paniker, I'm Chief Executive of the hospitals.
Jose Garcia, Local VP and Southend CCG.
Margaret Hathaway, Interim Accountable Officer for CCGs, CPR and Southend.
Sorry, son of the GP benefit.
Okay, thank you. And so, Michelle William, could you make yourself known, please? Would you like your question? Yeah.
Okay, so
So my question was about transport, because there doesn't seem to be enough detail provided about how that will work. My question is, what work and scoping has been done around this as part of the development of the business plan to consider its feasibility in terms of safety, in terms of staffing that transport, and in terms of cost? And I understand you've said that you will do some of that work following the consultation, but without that detail, I don't think that we as a public can respond to the consultation without understanding some of what that might look like. And my other question was around what engagement or discussions have you had with partners about what that transport model would look like, both with public services and private companies? And what would this new service look like? We need that information, I believe, before we can actually respond to the consultation. The transfer times in the papers that you provided today, I mean, I work in Chelmsford and I know the travel times, that it can take up to 2 hours to travel back in rush hour from Chelmsford. So the reality of what sometimes is presented isn't what we're experiencing.
Thank you, Michelle. Who'd like to take that question?
Introduce Ronan Fenton.
Oh, yeah.
Thank you very much for the question. So, first of all, in terms of much of the detail you request, there is a paper that will be published tomorrow, which will provide all of that and will be on the website. But just to give you the information, so what work has been done to date on patient transport, and I'm talking about inter-hospital patient transport now. So we have had discussions with the East of England Trauma Network experts, with North East London Trauma Network experts, with East of England Ambulance Service, with London Ambulance Service, with clinicians across the 3 hospitals to look at scope, the type of transport service that we will need to provide safe care for patients going between hospitals. We have published a document, first draft, to describe the spec of that service. I have explained it here on my last occasion as well, and for clarity, the proposal is that it will be a road transport service, it won't be an air transport service, because that has been looked at in other parts of the country, that the vehicles that will be provided for this transport service will be at national ambulance standards, that the staffing of the service will be appropriate to the individual patient needs, and we have provided within the document initial suggestion of a triage category to drive that process. We have provided details of the spec of the individual training needs of everybody required for the service. In terms of the funding, monies have been allocated for the service. Of course, the actual cost will depend on when we tender the service out to whatever organisation provides it, and the final cost is not right now known, but there are monies allocated for this service in the budget at present.
Can I ask who you are?
Thank you. Yes, this is Ronan Fenton. Sorry, you didn't introduce
Dr. Ronan
yourself.
Fenton. I'm one of the medical directors for the acute part of the STP.
Okay, thank you. Our second question from the papers is from Mike Fieldhouse. Could you make something up, please? There you go. Would you like to read your own question, Mike? Can we get a microphone? A mic for Mike, sorry.
Thank you.
Couldn't resist that.
My question is about the second principle, that more specialist services are needed for hospital stays that should be concentrated in one place. And it refers to the clinical evidence used to support the creation of specialist centres. I've had a look at many of your papers, and a fair proportion of the papers cited in your evidence pack do find a link between large volumes of operations carried out in hospitals and better outcomes for patients, up to certain limits, though the results admittedly vary widely between the type of procedures carried out. I couldn't read every paper cited, several behind paywalls, and I did find a couple that were in German or Polish, I think, so I was a bit stumped there. However, about half the papers I found were free to read, and I did purchase a couple of the papers that looked more significant. Some of the observations I've made from looking through this research on the specialist centres were that, almost without fail, the studies concluded that better results were not because hospitals carried out more specialist operations. It was down to other factors such as how these procedures were carried out and the level of care received. it was quite clear and stated in many of the papers that simply making a hospital's volume bigger did not itself lead to better outcomes, as you've implied in your case of creating specialist centres. Also, although a few of the studies used data collected from the last 10 years, the overwhelming majority of studies were conducted in the 1980s and 90s, with virtually none from the UK and a heavy reliance on American data, a country that has very different care systems to our NHS. Additionally, there was no consensus on the figure that constitutes high or low volumes across these studies. Sometimes we're looking at two different studies. One used a figure for a low volume that another study used and defined as high volume. Nowhere in your case can I find anything relating to how any of our three hospitals rank in regards to volume for operations carried out for these specialities that you plan to centralise. And for all I know, they might have high volumes in all three hospitals at present. What we can be sure of is there are many downsides to creating specialist centres, such as the fact that these will lead to Southend effectively losing a genuine general hospital fit for the needs of our town, as well as many problems associated with this difficult transport service that we're yet to hear the details on. I wonder, can you give me figures for the number of operations carried out relating to these complex speciality procedures, and how confident you are of the risk? How confident are you to risk the well-being of this area's residents based on this inconclusive evidence? I haven't just in the written question, but what I've heard tonight from both the renal specialist consultant and Dr. Skinner is that really we're looking at creating specialist centres as a last resort because we can't get enough staff to fill a hospital.
Can I ask you to conclude with your question now, please?
Well, that's my question. I haven't seen the figures related to it. I mean, you've given me figures that suggest there's 80,000 operations conducted throughout the three hospitals, and a rough breakdown suggests that maybe 9 or 10,000 of those are of these specialist operations. But nowhere have you said, you've given us this evidence, which I expect you probably didn't want anyone to have a look at, but it just doesn't look conclusive to me. There we go.
Thank you.
Yeah. Mike, I'm going to start, and then Emma's going to follow up. She's a general surgeon working at Southend. So in terms of the specialisms that we've described, which are limited in number, vascular, as an example, all the recommendations from national guidance show a really clear relationship that the more operations you do in one centre with surgeons doing more of a certain procedure, you get better outcomes. As you say, it's a complex picture. It's not just about surgeons doing the right number of operations, it's making sure you've got the right support around that surgeon in terms of anaesthetic support, recovery, nursing care. The whole package. It isn't just with the surgeon themselves. So that's why we've got to that position with vascular. The same argument follows through. You heard Gary describe that workforce is a key constraint for him in terms of how he delivers his service at the moment. That is not that we're describing a national shortage of renal physicians, it's that we're struggling to recruit those locally. And that is no doubt part of is if you're asking a renal doctor to work on an intense 1 in 4, 1 in 5 rota, that's not very attractive. If you can combine your renal teams to one larger renal team, or perhaps they work on a 1 in 10, 1 in 12 rota, that's much more attractive to do that hot, intensive week and then some other time where they can do outpatient work, teaching, training. It's a much better balance of work for clinicians. And there is already strong evidence that by beginning to combine these teams, often it is about combining the teams, if not the service in one place, that our recruitment is already improving. So our microbiology recruitment has improved, our interventional radiology recruitment has improved. There's 2 examples of already people knowing that these changes have come. In terms of the other service changes in respiratory, in gynecology, in trauma and orthopedics, where there is a very strong relationship in terms of volume, they have all been described by clinicians looking at their local current performance and comparing that to national UK performance, largely through a new data source for getting it right time data that is now widely published and is becoming a stronger and stronger data set. I'm going to stop there and let Emma talk a little bit about surgery.
So I think I don't know which studies you're talking about exactly, but there's very good data.
The ones on the STP document that are all listed.
You've got an evidence pack.
So getting it right first time, start of started to look at trauma and orthopaedics, and they got very good data which showed that if you had a spinal operation and you were operated on by a spinal surgeon that was doing this week in, week out in a unit, then your outcomes were better. They looked at high volume people not doing revision hits, and if you have one surgeon or two surgeons doing the revision hits for a large area, your outcomes and your recovery is very much better. 20 years ago, 30 years ago, if you came into a hospital with a surgical problem, you'd be operated on by a general surgeon. They may not have been a specialist in vascular surgery or colorectal surgery, and it was just the luck of your draw whether or not you got that case. Vascular surgery has evolved, and now if you have a vascular problem, you get operated on by somebody who does that day in, day out, which is better for your outcomes. Okay? Currently, if we look across our patch, we would love to have more surgeons, but unfortunately there aren't people out there to provide our middle grade rotas, as Gary is so rightly saying. However, the problem that you may get is that if you come in and you've got a perforated bit of bowel and you happen to come into Southend one day, you will have a general surgeon on, but it may not be a specialist colorectal consultant who's trained in doing keyhole surgery. And what we would like the situation is that where no matter where in Essex you were, if you came in with a bit of perforated bowel, you may get operated on with by a consultant colorectal trained surgeon, or you'll come in with a cancer and you're likely to go down keyhole, your outcomes will be better from the cancer if it is a cancer, and you're much less likely to have a stoma, okay, a colostomy. So what we're trying to describe is looking for those cases where we across the patch we would have enough to support that sort of rota, you get that expert care. Now 60% of all your care is going to happen locally anyway, because we've got better and better at doing day cases. So for most things won't change. So about 70% of your ENT it won't change. For a lot of your day cases, urology stuff it won't change. For other things it won't change. Breast surgery will not change. 94% of all breast surgery in cancers is now done as a day case. So we're looking at improvements across the patch.
I'm going to take a very... Thank you.
Could I just... I didn't get the question answered, though. I didn't get the question.
Sure it's questions and not speeches.
Yes, we've got a very short supplementary point, and then we're going to move on to the next question. Thank you.
It's just, can I ask Miss Gray then, the Royal College of Surgeon guidance states that yes, there is evidence for separating emergency and elective care, which is one of the big reasons you keep saying we've got to do this emergency surgery reconfiguration. But actually, that evidence says that ideally it should be on the same site. So for us here in Southend, who are going to be massively disadvantaged, in our opinion, by having emergency general surgery transferred up to Broomfield, because you need to separate... Well, no, just hear me out, please. So it does say on the same site for the separation between elective and emergency. It doesn't say 13 miles to Basildon and 22 miles to Broomfield. So can you just explain that evidence and...
So the model that we would describe is that you would come into your local hospital and you'd get assessed by a consultant or a senior decision maker in your surgical assessment unit. For the majority of patients, you wouldn't need to stay. If you needed to have your appendix out, or you came in with gallstones, or you came in with a surgical problem that didn't require an operation immediately, then you would stay where you were. But if it was the case that the person most suitable to doing that operation happened to be the surgeon on call at Broomfield, you might move. But for the majority of cases, you will stay where you are.
So if you make it to Broomfield, basically, is the long and the short of it. Yeah, please, no, tell us.
Whether you make it to Broomfield, it's where it will be where the most appropriate person. It may be that on that day, there is the right person at Southend to do it, but you will be stabilised and made safe and transferred.
I didn't get the question answered. I got a rerun of what's in the paper. I asked a question, I didn't get an answer. Can they tell me the numbers or not?
Well, I need to tell you, so it's about surgeon numbers, and there are minimum surgeon numbers per year for certain.
No, I'm just asking, do you know the volume numbers? That's what I asked for, because you've nowhere have you indicated how they correspond to the evidence that you've given me.
So that level of detail is coming through the next phase of planning in terms of going back to the figures that we've already described to then look at the actual surgical volumes to make sure that we, with the changes that we make, will get
after the consultation's closed.
We need to move on. You've got a written submission. We'll record that and move it on to the next.
I've got one question, and I think a lot of people have more faith in what you're saying and more courage in our convictions in what your policies. If the evidence that you're using, can be trusted. For example, you're quoting from the Royal College of Surgeons, you're quoting about elective and planned, but in their model, you have completely separate theatres, completely separate wards from the emergency service in the same hospital, and you divide that, and it's very expensive because you have to plan the organisation. But what you're suggesting is, well, we'll have planned operations over there, and a few beds put aside, and the rest over in Basildon, the emergency orthopaedics in Basildon. You're not actually following their guidelines. Secondly, when you're talking about the guidelines and quotes that you used in the evidence for the strokes and the stroke, you're referring to evidence of a model based in London, 8 acute centres or hyperacute centres, the stroke centres in London. Very successful because you go there straight away with a stroke. You are there with the team, with the specialists, and you get seen to right away. You're not flapping around, getting from hospital to hospital, from one surgeon. My mother suffered a stroke. It took 9 hours to get to the surgeon. 9 hours. She was in a bed for 5 years, so I know what flapping around can do for a stroke patient. So it is not the same model. The evidence you are quoting is based on different models. Can I ask you why that is so? Thank you.
I might start with the stroke question and maybe work backwards to the other question. But in terms of stroke, as I described currently at the moment, you present to your local hospital, which will offer thrombolysis if that is appropriate. And that, as you know, we hit very high standards in terms of the national data in terms of how quickly people are thrombolyzed currently. And then you receive that acute treatment afterwards. The proposed model is different from the London model, recognising the geography that we have in Essex and the concerns that people raised around that. So it is about making sure you are assessed locally, and if you require thrombolysis, that is given by the right people with consultant input from our stroke teams. But then after you've had that thrombolysis and you would benefit from that acute input, you would be transferred to Basildon. That is a model that is used internationally in Europe and the States. It is different from the London model, and it is different from our current model, but we have gone through a very extensive process in terms of examining the evidence, discussing that with the National Lead for Stroke, Tony Rudd, and we have agreed that this is the right model for our population, but obviously within that we will need to evaluate, and we will not go live with that model until we are confident that we've got all the pieces in place to make sure that the right scan can happen at the local hospital, the staff are trained in the expertise to deliver thrombolysis, and we can make safe transport.
Thank you.
You say that... Why would you use the evidence for different models to back this? That was my question. Why are you using evidence from a model that is different to the model that you are proposing to back up?
Okay, that's a clear question.
Roland's going to come in there and say, I've obviously misunderstood.
Yes, no, I understand the question, and it is really difficult, I think, for anybody to understand and to pull a single study out or to look for a single study that will demonstrate what we're trying to do. We have had the Academic Health Science Network examine all international studies from 1992 to 2016. Over 30,000 documents they examined. We have, if you look at the evidence for the specialisation, there are 68 separate studies provided there. But the reality is, and this is a reality in medicine we see all the time, there is no single study that provides the absolute confidence for the exact issue that you're trying to solve. So what we do is we look at the data, which we have done and which we have provided to you. We discuss it with our clinical colleagues who are experts in their fields. We sense check it with clinical colleagues who are not associated. So the clinical senate we have been to 3 times, which is set up to exactly do that. And I understand how frustrating it is that we can't say that study proves what we're doing. But the truth is, at the end of every study, in every journal, and I get 3 a month, and every one of them over the last 30 years of my career has said more work needs to be done to actually bottom this out. Not at all. I'm saying that we have weighed up the evidence that's available. We have discussed it with our clinical colleagues. We've since checked that with the appropriate national authorities, including the stroke experts and the clinical science networks and the clinical senate. And we have done that, and we have done that openly. We've been to the senate 3 times, and that is as much as one can do with the evidence that's out there to move forward. And by the way, it's quite a lot.
Thank you. There are lots and lots of other themes and questions that people have, so I'm going to go back to the model that we decided to do at the start and ask for people to ask their questions. We've got the next question.
Let Norman speak.
No.
He's an expert.
We need to move on.
Chairman,
Was it directly relating to what he's just said? Can you make it very, very short?
Chairman, you've got an absolute expert here in Dr. Norman Trout. Let him speak. Let him speak.
The lady asked first. We'll take that down.
Okay, let him speak next. He's an expert.
All your, what do you call it, proof, why don't you put the proof on the internet for everyone to see?
Okay, that's a short question, thank you.
It is there actually. If you go to the internet, and it has been there from November, if you go to the internet and you go to the website that we've provided, you go to summary of clinical evidence that we've reviewed, you go to the paper for the Eastern Academic Health Science Network, which provides all I've just everything I've said is available on the site.
Thank you.
We'll just get you a microphone, sir, okay?
Right.
If you'd like to say who you are at the beginning of your question, please, sir.
Norman Trow. You say that your evidence is clinically led. Now, when you say it's clinically led, is it clinically led by employees of the Department of Health who have a particular agenda because they have to ensure that that cuts are made so that the budget deficit is repaired, or are you referring to clinical consultants who are at the front line and who, in your own departments, you have who do not agree with the plans that you have made? For example, the question of respiratory illnesses having to go to Basildon, non-invasive ventilation, respiratory cases like pneumonia. Some of your own consultants are saying this is the most dangerous idea that I have ever heard. So please tell us, when you say they are clinically led, are they the consultants in the hospitals in Southend? Have they all been? Are they all in agreement with this, or is it the full-time employees of the Department of Health, like Dr. Skinner?
That's a very clear question.
Employee of the Department of Health. I'm employed by Basildon Hospital. I've been an NHS consultant now for over 20 years. These plans have been drawn up by our local consultants, our local leads. Who have responsibility to be it the respiratory team, be it the renal team, the general surgical team. We've got representatives here. That is based on national standards that they should be working to, and looking at the clinical evidence that is available, and then relating that to our local situation, both in the terms of the resource that we have now, and the resource that we will want to have for the future, and to plan for the future. This isn't just about what we want to deliver in the next year, it's for the next 5, 10, 15 years, and trying to think ahead. Anybody want to come in terms of the clinical engagement that we've had around the plans?
No, we've all been involved with teams. So
in surgery, even a year ago, the whole of the breast surgeons in Essex met up. We agreed, we looked at our units, we worked out what was going to work, the general surgeons, we've all met up, all the surgeons from all 3 hospitals. We've looked at the processes and plans, we challenged some of the plans and gone, this can't work, but we think there's another way that can work together. So some of the plans have evolved, and we've looked to work out how we can, with this opportunity, actually improve things for people. We know that in an ideal world, we'd have, we'd all be fully staffed, and we spend our time endlessly. It's not for want of trying to be cuts. It's just that sometimes there's physically aren't the people out there. And if you're talking about a respiratory unit, it would be nice to have a respiratory specialist doctor there 24/7 on your non-invasive ventilation unit. That doesn't happen at the minute. It will be just the medical registrar on call overnight. So we are, this is an opportunity to improve things.
So, and in answer to your specific question about respiratory medicine, so the plans have evolved from the PCBC and are now do describe only moving a very small number of patients with complex lung problems who may well benefit from an earlier diagnostic procedure or an earlier surgical intervention. So the plan is only about moving those patients. It is not about, we will maintain non-invasive services at all 3 sites because that's in the best interest of patients.
Thank you. We've had lots of questions on the theme of the evidence and some very informed comments from the floor. I'd like to move on because there are other very important issues. There's a question of the merger, and I have a question from a lady called Laurie. Do you recognise yourself in the question? Would you like to read?
Yeah, because I wrote so many I can't remember.
Okay, that's fine. Okay, this is probably best for Claire.
Yeah, I'm just concerned that you're going to merge the 3 hospitals. You're talking about moving all of a lot of services away from Southend Hospital. My biggest concern is this a way of eventually downgrading Southend, leading to the eventual closure of the hospital?
That's a good question.
Yeah, so I think we really need to address this one head on. This is not about the downgrading or closure of any of our 3 hospitals. Each of the communities that the hospital serves need those district general hospitals to be available. There is no possible way that we could manage with the demand that we have without all of our hospitals working at the capacity that they are now. So there are no plans to remove beds. The bed numbers at Southend, in fact, are projected to increase by about 50. So there is absolutely no intention to close, downgrade Southend Hospital, or any of the hospitals for that matter. The merger makes it easier for us to work together, but as Celia pointed out earlier in her presentation, any clinical change, any service change is decided by commissioners following a period of public consultation. So it does not shortcut any ability to change services. And actually what we're motivated to do is to try to ensure that all 3 of the hospitals are sustainable and that they can provide better quality care than they do today. That's the driving motivation for all of us about these changes.
Thank you, Claire. We'll move on to another thing. Does anybody recognise blue cards? Is that you, sir?
Really quick question, Claire.
Quick, make it a quick question, please, so we've got time for everything else. Thank you.
You've agreed to see through these cuts. How are you going to see cuts nearly 200? How are you going to see through these cuts and not see downgrading of services? How are you going to see through these cuts and not see staff move, staff leave, patients waiting longer? I'm really struggling to understand how you've got the best interest of the patients at heart when you've agreed to see and acknowledge and push through these cuts.
Thank you.
So we have... So you'll know that we're running a large deficit, a large financial deficit across our 3 hospitals. If we continue as we are, that deficit will grow and grow and grow, which is fine if we have got the money then to pay for the products that we buy and the staff that we employ. I'm not making a party political statement here. I'm just reflecting the reality that we don't actually have enough money to run the services in the way that we are running them now.
Why?
Pay more income tax then.
Well, I'm afraid I can't answer that question.
No, you can't. You can't answer any questions. The answers you have so far have not been answered. You can't answer anything.
Okay, well, we'll move on to other questions now. Does anybody recognise this? Who's written their questions on a blue card? Nobody recognising that? Okay, we'll move on to John Gippin. Oh, sorry. You're behind the... I couldn't see you behind the pillar. I knew that was going to be an issue. Would you like me to ask it for you?
If you notice, she's now talking in the context of the STP
so this is relating
and
to
the
community
merge of the
plans in
trust
care.
together.
That one? Yeah. Okay, so what evidence is there that the proposed community plans will be able to be implemented?
We had it leaked to us that
in terms of
hospitals
general
were merged.
practice, so one
They
of the
haven't.
problems which
I
everybody
went to Health
realises
Service
is
Journal
we've
and
got
they
big shortage of
inquired
general
with the
practice,
hospital.
general
And the
GPs in
day
this
they were going
area.
to publish
Some of
hospital
you probably
amounts
experienced
that they were having that meeting.
So the question is, what can we do about
I don't think they'd have told
so
us
one of the
otherwise.
things we're trying to do is attract GPs into this area. But that's only going to be part of the solution. There's quite good research which says that 1 in 4 consultations which are currently done by GPs could be done by other people. So if you have a musculoskeletal condition, rather than see your GP, you see a physiotherapist straight away, and they can give you appropriate physiotherapy treatment. If you've got chronic conditions which can be managed better by advanced nurse practitioners than myself, and it's better you can see an advanced nurse practitioner, or you see a mental health therapist if you've got anxiety and depression. So that's one part of the solution in terms of those patients who can be treated just as well by other clinicians, and that would leave time for GPs to spend more time with those patients who have got more complex conditions, who need more time because they've got multiple conditions and got multiple medications. The other thing which will probably help in terms of recruitment is the Anglia Ruskin University, which is likely to be a medical school in September, and that will hopefully help us to attract GPs into this area. So recruitment is difficult, but there are plans to try and address that.
Okay, thank you, Senator. On the same table, we've got a very short, you promised me, follow-up point or question.
Talking about moving the things like physiotherapy to speaking to somebody other than a GP, I recently had a case where I needed to see a physiotherapist. I was given a phone number. I took 4 days to get through to speak to someone on the phone, and he said to me, when I'm in my lounge, I'm going to get you to stand up so that I can have a look at how you're moving. He said that to me over the phone. I'm sure he was thinking of having someone in front of him, but if you have a musculoskeletal problem, I don't think it's appropriate to speak to somebody over the phone as your first point of contact and then be given 6 to 8 weeks to wait for an appointment to see somebody.
Is that a point or a question? Sorry.
Well, you know, it's all right to say don't go and see a GP, see someone else, but in that case, that's not. How does that help the patient who's got a problem? How does that help them? It doesn't. They need to see a GP. They need to see someone.
So what we're talking about is seeing a physiotherapist face to face, not over the phone.
But that's what's offered. That's what's being offered to us.
This is the proposal.
So, in terms of can physiotherapists do, my personal view is that physiotherapists do much better assessment if it's face to face. And in terms of the general practice.
Palpated abdomen, by the way.
Sorry, sir?
Can Skype palpated abdomen?
So I'm not talking about Skype consultation.
No, but what I'm saying is that this lady's right. The downgrade of everything is wrong.
So
The downgrade of these services is totally wrong. And in actual fact, without the staff available, this is what is happening routinely in mental health, in physical health, in hospitals, and in general practice. And in actual fact, you cannot fit a quart into a pint pot. What I would ask is, why is it that you are all so happy to accept these £22 billion of cuts when it's actually people's lives that you're talking about, and actually having blood on your hands?
Yeah. Jose's got a question to the lady at the back.
Can I answer to the physiotherapy point? So the usual way that we had before to refer patients to physiotherapy is you see the patient, you feel that there may be benefits in a physiotherapy. What we were doing is doing the referral was seen, was treated by the physiotherapist team, and they decided on the appointment. In conversation with the hospital, with the trauma orthopedic and physiotherapy, we thought, we will see if we are right or wrong, that maybe better if the patient can have this initial conversation ideally quickly, yes, because it's an advice and an assessment service may take few, so they may not be the first day. We try to address that. But the idea is that the person can have this conversation with the physiotherapist, and then through this conversation, the patient may benefit from seeing a physiotherapist earlier than if it was done with the usual referral system. If actually, but we want your feedback as GPs. We want feedback from the patient because we are working with this with the hospital. If the system in some cases is not working as expected, then we will want to know, because then we will work with the hospital trying to improve the system. But the idea is that you can have the conversation with the physiotherapist. The physiotherapist can hear from you what the problem is. So ideally, they can give you an appointment earlier than the usual referral.
Okay, thank you. There have been lots of questions about the consultation process. You remember that was raised early on in the session. I've got a question about this process from John Dickens. That's you, sir, okay. Do we have a microphone for John?
6 minutes to go and we've discovered nothing. Other than the fact it's a load of old bullshit.
As you're probably aware, the majority of the audience are highly sceptical of the proposed changes. Can you assure us that this public consultation is not merely a box-ticking exercise where our views are noted and ignored, or can you reassure us that our concerns will actually be acted upon?
It's not a democracy.
Just before the panel answers that, because I'm here for timekeeping as well, we've got just around 5 minutes to go, but I'd rather get through these last 3 questions fairly quickly so that we've at least covered most of the bases. So, great.
So I can answer that. So I can assure you all of the comments are going to be collated and answered. And in fact, a lot of the comments, lots of the questions have already been answered and on the website. All of that will be assessed by an independent group of people. That will all be collated and that will all be presented to the Joint Committee where the 5 CCGs sit around that and look at all of the questions, all of the evidence, all of the responses in order to make that decision.
Okay, thank you. We've now got a question from, I believe, forgive me if not with the handwriting, I believe it's Councillor Terry from Southend. Is that you, sir? Yeah.
I've got a big mouth, it's okay.
Have the microphone. Have it.
Okay, thank you. Why has the financial information on the STP website been changed and made more difficult to understand? Are the required savings still 407 million as published by the STP in May 2017? Or have they increased reportedly now to 530 million? Can we please have a bit of honesty about why we're doing all this process?
So the financial information obviously is, as we move on through the financial year, financial positions change. The actual saving that we have to make is still around the ballpark of 400 to 500 million. It's not an actual saving, that is saying that if we carried on as we are, £100 million or so deficit each year, at the end of that period we would end up with a 500 million deficit. But we have to find ways of correcting it through this process. So there is a financial dynamic to this, of course there is.
The mic's going to start.
I think what frustrates everyone in Southend and also politicians, by the way, we weren't even informed about the merger of your trust. What really frustrates us constantly and makes me actually quite angry, I'm an independent politician by the way, is the fact that you keep on saying this is clinically led and it's about better patient outcomes. Well, I'm sorry, it's about cuts. It's about time we all face up.
So I don't think there's ever been any question that there's a financial element to these proposals. There is a workforce element to these proposals, and the clinicians and the management of the hospitals and the CCGs have the challenge of trying to ensure that we provide a quality, safe service with the resources that are available to us, and the clinicians have come together and decided that these proposals present the better way forward and will lead to better outcomes for patients. Now,
not for the people
we
in
have got
Southend.
waste in our system, as we know. We use far too many agency staff. We don't. So we can work more effectively and more efficiently, and we need to make our hospitals more attractive for people to come and work. And that's a lot of what you've heard
paid for all this?
tonight.
Who paid for all this? Who paid for this nonsense? Who paid for this
£500 million.
pantomime?
You ain't going to find that in the
That could be
cupboard.
you to treat patients. Who's paid for this pantomime, by the way? Who's paid for the bouncers?
Next question, please.
You know, we're cutting and cutting and cutting at the thing that matters. You know, where's the balance in this? You say better clinical outcomes.
Please. Just another question.
So there are other questions coming. The lady with her hand here has a short supplementary point relating directly to this, is that correct? Okay, we've got a microphone for you.
With the merger of the three hospitals, will you be doing central buying, or will it be as it is now, ward by ward? And I've got evidence of that.
Thank you. Thank you for a well-constructed question.
The plan is definitely to bring all of our buying and procurement together so that we get better value for money through the purchasing power that we have from a £900 billion organisation.
So that's flawed.
Excuse me, sir.
Yeah, but that's flawed because they tried that in schools.
Excuse me, sir. Can we have a microphone so other people can hear what you're saying?
That is...
Just a second.
If I might just say, that is flawed because they tried it in education. All right, the price is the price. And you can actually, if you wanted to, you could get into a consortium with the three hospitals and every other hospital to do that. That is flawed. And the other point I'd like to make is, how do you expect the staff to go back to you when their working conditions are so bad, when they go to agencies because the agency pays more than they do, and they can actually choose when they work, and if you're going to put these specialist staff to Chelmsford or Basildon, and Michelle has already said that it's a 2-hour journey, they're not going to want to do that. They want the flexibility. They're not worried about their pensions in the future. These are often people with young families and they want their money now. And I really don't think that I would be very interested to see who's your consultant. We've heard about the clinicians being consulted. Speak to the people on the ground floor, because I'm sorry, I'm going to make a judgment of you, but you are out of touch with those people.
As I said earlier, we need to finish very, very shortly. I'm going to take one final question that we have here. Again, I'll try my best with the handwriting. I believe this is Betty McCarthy. Is that you? Okay. Would you like to read your question? We've got the microphone just here.
Right. I understand possibly why you want to merge Southend and Basildon, but why the outline via Broomfield? If South Essex splits from Essex County Council, could make it very difficult.
Thank you. Who'd like to take that?
I mean, the STP was established to cover all three hospitals, Broomfield, Basildon and Southend. We already have lots of services that work across the patch. So our burns and plastics, our cardiac services, our cancer services already work in tandem. I think the other point is that in planning the services that we're talking about now, doing that on a template, a footprint of over 1 million population allows us to get the benefit of that scale.
Okay, thank you. As we know, we've overrun the time. Thank you for the final question there. As we said at the beginning of the session, this isn't the end of it. The questions that you've written down will be looked at further. I'm going to ask Margaret to do a final statement, please.
Okay. So thank you all for coming this evening, all for the constructive feedback. As we have said,
all of those comments will be collated. We're coming towards the end of the consultation period now. There's a few more events to take place, and there's a team throwing away all of those questions that are coming, and to make sure that we get responses to those, and to collate the report that's getting ready for the decision in the summer. So once again, thank you all for coming. It's been really, really good questions. We want to hear your views.
No, you don't. No, you don't. You do not.
It's really important that we
45 minutes is all we've been allowed.
So that we can move on. So thank you.
45 minutes is not enough for public questions at a public consultation event. 45 minutes, that is all we've had. We do not think that's acceptable.
We've also got representatives of the ambulance service here.
Yep, sitting over there.
They're not allowed to speak. They won't speak anyway.
Sorry. No, what I was going to say was, so much of these plans is about transport. You're the experts. Why aren't you being given an opportunity to talk to us?
You didn't ask the questions.
So they won't be engaged.
No. You picked the questions that you wanted to answer.
They don't want to engage.
At the time,
Right, and then we let's go because it's utterly pointless.
It's utterly controlled. A farce, an absolute farce.